When you think about businesses that are selling through the roof, like Skims or Allbirds, sure, you think about a great product, a cool brand, and great marketing. But an often overlooked secret is actually the businesses behind the business, making selling and for shoppers buying simple. For millions of businesses, that business is Shopify. It's home of Shop Pay, the #1 checkout in the world. You can use it to boost conversions up to 50%, meaning way less carts going abandoned and way more sales going through to checkout. Upgrade your business and get the same checkout Allbirds uses. Sign up for your $1 per month trial period at shopify.com/income, all lowercase. Go to shopify.com/income to upgrade your selling today. Shopify.com/income.
Hi everyone, I'm Deb Flashenberg. Welcome to Yoga, Birth, Babies, a podcast produced by Prenatal Yoga Center. We will be diving into everything prenatal yoga, birth, and baby related, hoping to inspire, educate, and empower you through your journey into motherhood. Thank you for listening.
Hi, I'm Deb Flashenberg. I'm your host of Yoga Birth Babies, and today we're talking about the ARRIVE trial, and specifically induction at 39 weeks. Now, the reason I wanted to do this podcast is because I'm hearing my students all the time saying, "Oh, I'm going to be induced at 39 weeks." And I'll say, "Oh, okay. How do you feel about that?" They're like, "Oh, I didn't know that I could feel about it because my provider said this is what we do at 39 weeks because the ARRIVE trial." And so while I have had a podcast about this already years ago when this first came out, I wanted real expert advice on this because it is happening a lot. And is the ARRIVE trial really informing what's happening in our hospitals now? So I reached out to Dr. Elizabeth Langen, and she is a maternal-fetal medicine specialist and associate professor at the University of Michigan. She has led a statewide initiative to improve the vaginal birth rates in the state of Michigan through collaboration with nursing, midwifery, and obstetricians. She's currently directs the Cardio-Obstetrics program at the University of Michigan that aims to provide clinical home that is patient-centered for people with cardiovascular disease before, during, and after pregnancy. This conversation I have with Elizabeth is so down to earth, and she is very open about sharing the facts, the pros and cons of induction, and really describes the ARRIVE trial in the controlled trial, as well as what it looks like in real life. Are we seeing the same protocols that they used in the trial applied to most labor and delivery units? And it's a really interesting conversation. We also dive into the pros and cons of induction. She talks about preeclampsia. It's really an interesting conversation. So if you are pregnant or you support someone that's pregnant or the partner to someone that's pregnant, and they may be being told, "Oh, you should be induced at 39 weeks because of the ARRIVE trial," this might give you not just pause, but some great questions to make sure that you're getting patient-centered care, not a one-size-fits-all protocol. I'm really excited for you to hear this conversation. Now, before we dive into this conversation with Elizabeth, I always love to give updates about what's happening at Prenatal Yoga Center. So some interesting, exciting things happening. Best thing to do really is to head to our website, prenatalyogacenter.com. You can check out our in-studio and our on-demand classes, our online classes, our workshops. But something that's really exciting is you'll start to see the PYC method beyond New York City and beyond our classes online. We actually now have some of our graduates teaching the PYC methods all over the world. And it's something I'm really excited about. So we're going to be putting on our website the links to the schedules of other teachers outside of New York that have studied the PYC method, and you can take classes with them. I'm so excited to be expanding and supporting our teachers in that way. So you don't have to be in New York to take our class, and if you don't want to do it online, you can still take it in person from some of our graduates. I'm really excited about that. We also, if you are a yoga teacher and you're interested in learning our methodology, check out our teacher training. We offer it 4 times a year. 1 time in person in New York and 3 times online, which is how we've been able to spread this method all over the world. It's really amazing how many students we've had all over. I know I'm kind of getting excited about this new opportunity. All right. I think that's enough from me. I just want to say thank you for those that listen. Thank you for those that have left a rating and review. Thank you for those that have sent me ideas for people to reach out to. And thank you to those who have filled out an application to be on the podcast. It's really thrilling to be able to support you, the listener, and for you to support us here at Prenatal Yoga Center and Yoga Birth Babies. Okay, that's enough of me. Let's take a super quick break. When we come back, please enjoy my conversation about the ARRIVE trial. Hi, Elizabeth. How are you?
I'm doing well. Thanks for asking. How are you?
I'm doing great. I am really excited to chat with you about the ARRIVE trial. When it first came out, I had a conversation with someone that did a lot of, it was a childbirth educator, but I feel like I'm hearing about it even more and more, which is why I did a deep dive and you came up in my research. So I'm so excited to dive into this. But before we get into the info, I would love to learn a little bit more about you and what led you towards obstetrics and also your initiative to improve the vaginal birth rate in the state of Michigan.
Awesome. Thanks. Well, when I entered medical school, I didn't really know what type of doctor I wanted to be. And when I was a first-year medical student, there was an elective class that you could take. It was called Mommies and Babies, which is maybe a little bit pejorative, but the effort was great. And what we did in that class was pregnant people would volunteer to let medical students come with them to their visits and attend their birth. And then we would have lectures teaching us about both pregnancy as well as like early childhood care. And the wonderful person who let me attend her birth, it was her third child. The delivery was managed by this like beautiful senior midwife who had been delivering thousands of babies over a lifetime of a career. And the birth was this like amazing vaginal delivery with soft white lighting and her husband supporting her. And it was just the most amazing, beautiful thing I had ever seen. And I could not imagine doing anything else with my life than being a part of that process. Interestingly, about 3 months later, I had done a summer internship with one of the hospital chaplains. And as a part of that experience, I met a young woman who was about my same age who had been diagnosed with something called peripartum cardiomyopathy, which is basically when your heart goes into heart failure, either just at the end of or immediately after delivery. And I spent my summer talking with her, talking about her newborn baby, and unfortunately watching her die. And she passed away at the end of that summer. So the combination of experiencing that amazing, beautiful birth, and then that horrific tragedy of a young mom passing away and not getting to be with her child just really focused my sort of intentions with medicine on wanting to be not only an obstetrician and gynecologist, but really someone who could help take care of people who had complex pregnancies and complications with their pregnancies.
Oh, wow. Wow. That is powerful. What led you to your initiative to improve vaginal birth rates? Because that is not something that every care provider thinks about doing, but that is something that you're kind of at the forefront of.
Yeah, so in the state of Michigan, we have a big network of these quality improvement initiatives that are actually funded by Blue Cross Blue Shield. And they have been working for many decades to try to improve care in different disciplines. And there actually had not been one looking at women's healthcare in particular, and certainly not looking at obstetrics. So we were offered the opportunity as a part of the obstetrics initiative to do some quality improvement work in the pregnancy space. And they actually challenged us to look at the vaginal birth rate. And it's something that, there are occasionally some folks who come in and really do want to have an elective cesarean delivery, but for the vast majority of women, successfully having a vaginal delivery is their goal. And it is a complex process to try to help as many people as possible get to that goal. So I was just excited about the challenge of really trying to impact how people experience their birth process. And grateful for the opportunity that I was asked to participate in that.
Oh, that's wonderful. And I'm really glad because I do believe from I'm going to really date myself, my 23 years of working with pregnant folks, that rarely do people say they go in for a vaginal birth, and sometimes they're disappointed they didn't have it. Sometimes they're thankful they had it, but it's rare that someone does have an elective C-section. When they do, I 100% want to support them with information how to prepare for that. But I completely agree that many want a vaginal birth, but it's kind of staggering that our statistics don't really support that. About a third of babies are delivered via cesarean. So let's jump into some of these studies. And I think I'm really excited about this question because I think people can Google pretty much anything. And honestly, I think kind of find studies that support both sides of things. So when people are hearing headlines about studies, I feel like there's a lot of confusion. So can you start with explaining the difference between randomized control trial and real world clinical data and why they both matter? Because when we talk about the ARRIVE trial, I think these are really important facts.
Yeah, absolutely. I think that's a really essential question to ask. So a randomized controlled trial is a kind of study where you take people and literally with a random number generator, randomly assign them to one of two different groups. So you really try to eliminate, and most randomized controlled trials, including the ARRIVE trial, successfully eliminate biases in how people are treated. So for example, when we think about induction of labor, there certainly may be biases in which types of individuals are recommended to have an induction of labor at 39 weeks versus which types of individuals are not, based on the biases of not only people and their experiences, but also on care providers and their, preferences and attitudes towards different modes of delivery. So what a randomized control trial tries to do is take away all those biases by both the clinical team as well as the individual patients and say, if we just randomly assign people, can we see what would happen? And when the ARRIVE trial was conceived, the intent of the authors was to try to see if they could decrease actually the stillbirth risk, or the risk of, the worst outcome for most moms is losing their little one. They actually had a combined outcome that includes stillbirth and some other very serious adverse outcomes for the babies. But that was their goal. They were trying to see if we induce women at 39 weeks, would that help babies have better outcomes? And what they found is that there was not a better outcome for the baby. If you happen to get induced, or if you were expectantly managed, meaning no one induced labor but kind of waited to see what would happen with your pregnancy, there was no benefit for the babies. But the challenge is, one of the second outcomes of that trial was looking at how having an elective induction of labor at 39 weeks impacted your risk of having a cesarean delivery. And this was not the primary question of the trial, but was an intended secondary question. And I think this kind of question is a little bit problematic when you think about what happens in the real world. Because in this randomized control trial, while you've eliminated biases, you've also created kind of a unnatural environment. Because when you're in a randomized control trial, you are following a very specific protocol. People are going to be very sure and thoughtful that you don't have any reason that you shouldn't be included in the study. They're also going to make sure that when you're in the study, the protocol is followed very carefully. So nobody is accidentally doing a C-section without a good indication, because they're making sure that if you have a cesarean delivery, it's because there's a clear reason for it. And there tend to be research nurses who are making sure everything is done properly and correctly. And that helps us figure out kind of some of these more objective outcomes, but it introduces sort of a false environment for some of the outcomes that might be really influenced by the environment. So when you think about cesarean birth, we know from lots of work done by a lot of wonderful people, Emily White Van Gumpel is probably the leader in this space, that the culture that surrounds you when you go into a labor and delivery really influences your risk of a cesarean delivery. So if you do a study in sort of this false culture of a randomized controls trial, it's hard to extrapolate those findings into real world labor and delivery practices that don't exist in that type of very tightly controlled environment.
One of the things, and you'll know this far better than I will, when I did do some research and talk to others, the timetable seemed to be different. That I know, at least I can speak to the New York hospitals, there is definitely a ticking clock of how long you can push, how long you can labor, how long you can labor without Pitocin. And it seems that in the ARRIVE trial, it was more spacious, for lack of being more scientific.
Yeah.
What are your thoughts on that?
Yeah. So, the ARRIVE trial, their goal was to use the definitions of prolonged labor and when you would be recommended to have a C-section that are supported by ACOG, which is the American College of Obstetrics and Gynecology, as well as the Society for Maternal-Fetal Medicine. And, part of being in a trial is making sure that those guidelines were followed, that people didn't do cesarean births sooner than they should have because of a quote unquote prolonged labor. And I think you're identifying a real key factor there. In the real world, not everybody follows those guidelines. As part of the obstetrics initiative, one of our first assessments was how often are people following those labor length guidelines? And we found that a huge number of cesarean births were being done for what we call arrest of labor, but people had actually not been allowed to labor for as long as the society guidelines would suggest. So absolutely, I think the non-adherence to guidelines that happens so commonly in sort of general practice isn't really accounted for in the context of a randomized control trial.
Yes. And that is like something I want to highlight and put like bells and whistles around, because I don't see this happening in the hospitals like you're saying. And one thing that I'm seeing from my students over and over and over is I'm being induced at 39 weeks. And I'm like, oh, and I really try to be open. I'm like, oh, how do you feel about that? And they're like, I really didn't want to be induced, but I'm 36, or the ARRIVE trial says my doctor wants me to do this. And I try to stay in my lane and just be like, here's some facts, which is again why I'm doing this podcast. But what would you say to those listening that their doctor is telling them, oh, you should get induced because of the ARRIVE trial and the findings? What would you just blanketly say to that?
Yeah. So the ARRIVE trial was uniquely looking at very low risk women. So if you have a medical condition that suggests you should be induced, you wouldn't have been a candidate for this trial. So it's really was looking at very low risk pregnancies where objectively there wasn't a reason that they had to deliver at 39 weeks, which is a week before someone's due date. So, the ARRIVE trial may or may not apply to your client because they may or may not actually have a low risk pregnancy. The thing that I would say from the ARRIVE trial is, it did show a decrease in preeclampsia, which is a high blood pressure disorder of pregnancy. And that's something that we found in our research as well. So that's a pretty consistent finding despite different methodologies. So if there's a patient for whom preeclampsia would be particularly problematic, like I said, I take care of a lot of people who have heart disease during pregnancy. And for a lot of them, if they got preeclampsia, that has a different level of risk than the average person. So for some people, getting delivered early makes some sense. For some people, getting delivered at 39 weeks makes sense from a childcare standpoint because they want to coordinate and things like that with their lives. But everything has risk and benefits. So I think it would be important to talk with your doctor about, what are the actual benefits that I'm getting from my induction of labor, but also what are potentially the risk of that labor induction.
And then maybe also bring up, if we are using the ARRIVE trial as the reason to be induced at 39 weeks and they otherwise are healthy, will they be given those same guidelines? I'm just kind of tossing that out there. What do you think?
Yeah. Yeah. I mean, again, the ARRIVE trial applied to very low risk, healthy people for whom there was no reason they should get delivered. And it did show some benefit in reducing preeclampsia. So if that is of concern to someone, like that is a thing that they showed and we should as well. But it also, you also spent longer in labor and delivery in the hospital. And that may not be something that people want for their birth experience.
Right. 100%.
And so when I say risk, it's not just like the medical risk, but it is kind of thinking about what's most important to you in your birth experience. And for some people, having a spontaneous onset of labor, not spending a significant amount of time in the hospital, for a lot of folks, those are very important values. And this small decrease in the risk of preeclampsia may not offset those.
So you've analyzed the real world data from Michigan. What did the data reveal about cesarean rates? Like, because you're talking about length of hospital stay. So let's jump into that. And then also the trade-off for parents.
Yeah. So what we did was, as a part of our efforts to decrease the cesarean birth rate for first-time moms, we collected a lot of data on first-time birthing people in the state of Michigan. And what we did in this particular study was we looked at folks who did not have any medical reason to get delivered. So not people who had diabetes, not people who had hypertension. So healthy group of folks. And we looked at people whose doctors scheduled an elective induction of labor at 39 weeks, or their midwife did, and compared them with folks who similarly had no medical complications, but were 39 weeks and did not get a scheduled induction of labor. So really tried to mimic what had happened in the ARRIVE trial, though these people were not randomized.
Okay.
And when we did that, whenever you do this kind of study, you always start by looking at the two different groups. And when we did that, we found that in the state of Michigan at the time, this was 2020 data, the people who were having 39-week inductions had some demographic differences from people who did not. So they were a little more likely to be over the age of 35. They were a little more likely to be non-Hispanic white. They were a little more likely to be obese, and are more likely to have private insurance. So there are different demographics there. And so if you look just at those two groups, acknowledging that demographically they were different, we actually saw a higher risk of cesarean birth for the labor inductions. And so if you were a nurse working on labor and delivery, that's kind of what you were seeing. People who came in for labor inductions were more likely to have a C-section. But we wanted to dig a little deeper in the data. And so then we set up our study a different way. And we said, well, what if we control for some of these demographic differences? And we take all the people who had an elective induction and find a demographically similar group of people who had expectant management. And when we did that second analysis, what we found is actually there was no difference in your risk of C-section. And so it maybe didn't really matter if, in terms of your C-section outcome, whether you had a labor induction or expectant management at 39 weeks. But it did show us that folks in both groups, the demographically similar and dissimilar, if you had an elective induction of labor, you spent extra hours on labor and delivery from the time of admission to the time of birth, which is not unexpected and was also found in the ARRIVE trial. And we did find a significantly lower risk of hypertensive disorders in both groups.
Interesting. So because the longer, I'm assuming that the longer time was, if it's spontaneous labor at home, they're coming in when they're likely in active labor. And if it's induction, they have to get induced, start with, cervidil, start with fully, like, so it's kind of start from scratch.
Absolutely.
And that could be up to 12 or more hours.
Yeah, absolutely. It could be a significantly longer period of time.
Right. So let's actually jump to, from your perspective, what are the this is just your perspective. So people out there don't be like, oh, there are other advantages or disadvantages. What are the true advantages of labor induction, and what are the potential downsides? Because you did talk about extra time there. Is there any other thing that you see important to highlight?
Yeah. So I think the main medical advantage is you decrease the risk of hypertensive disorders of pregnancy, which are, a big problem. So that is a good thing to avoid. For some people, there is comfort and a little sense of control if you can pick a date for your delivery. So I do feel like some people find that advantageous. Some folks, if you're getting delivered at 39 weeks, you don't have to go see your, midwife or OB provider at 40 and 41 weeks. And so it saves you some office visits. And I think, the gamble that you're taking by staying pregnant at 39 weeks is you're hoping that you're going to be the person who spontaneously goes into labor in the next week or two. But there is the possibility that you may be the person who doesn't go into labor and now is more than a week or so past their due date. And then we do know that if you'd have a labor induction at more than 41 weeks of gestation, your cesarean birth risk does go up. And there's lots of hypotheses as to why that might be. But your cesarean birth rate goes up and the risk of stillbirth does go up once we get past 41 weeks. And so you avoid that scenario. You avoid ever becoming 41 weeks pregnant and having to decide what to do at that point. So those are kind of the advantages. The disadvantages are you will spend more time in the hospital, like we were talking about. Inducing labor takes a while. You don't have the advantage of spontaneous labor, which for some people is a really natural and very important experience and part of their birth process. And you exclude the opportunity to have that experience. And it does sort of medicalize your birth in a way that it's hard to avoid, because once you've started an medical labor induction, your healthcare team is going to be doing stuff to you. And so you lose the opportunity to have sort of a more natural experience that avoids a lot of procedures and medications.
Yeah. And there are also a lot more, for lack of a better word, gadgets kind of attached to you. You're a lot more tethered. And I'm only thinking of that as when I was an active doula, helping people move when they had the blood pressure cuff and the oximeter and the fetal monitors. Like, there's a lot on your body, and just even rolling over from one side to the other in bed, we're having the wires. And if they don't have an epidural, they can stand, but we do have like the pole, with like the pit going on.
100%.
There's a lot of gadgets.
And we try, like, some of, there are hospitals that have like wireless fetal monitors, so you get rid of some of the wires, but you definitely have an IV pole if you're getting Pitocin. And, the monitors, generally for giving folks a medication, we're going to want to monitor the fetus. Whereas if you have spontaneous labor, you can do intermittent auscultation. So it does change the whole sort of vibe, for lack of a better word, of like what your birth experience is.
Yeah. It's a lot of tethering. All right, we're going to take a quick break. I know, I have no other word. Yes. We're going to take a quick break. And when we come back, let's talk a little bit about perspectives from OBs and midwives and just other providers. So we're going to take a break. We'll be right back. Okay, so we're back. So it's interesting that I've really witnessed this in class, and sometimes I just kind of sit back and watch the students talk, that our community has, some people use midwifery care. We have a wonderful midwifery center on the Upper West Side called ULA, and then we have a lot that have OBs, and then some that have more liberal OBs in terms of like they almost practice like midwifery. So there's a lot of different perspectives. And what I find that the students often feel overwhelmed when one student's like, oh, my OB says this. Oh, my midwife has said this. Why do we think the professionals in basically the same arena assess the risks and benefits so differently?
That is a great question. And I have ideas, but I will not claim to have the final answer on that, because I'm sure if you asked 4 people in this profession, similarly, you get 4 different answers. But I think a lot of it comes down to what you have experienced informs like your biases going into the conversation.
That makes sense.
So, when we first started talking about decreasing the cesarean birth rate, I will say that this collaborative that we have in the state of Michigan included midwives, obstetricians, as well as many nurses who are labor and delivery nurses. And the nurses, for many of them, a very immediate answer was, we'll stop inducing people because those are the people who get the C-sections. And they weren't wrong, right? Like if you looked at the people with the elective inductions, there were some demographic differences, but they had a higher C-section rate. Now, if you control for those demographic differences, maybe that wasn't statistically true, but that their lived experience was these are the people who were seeing ending up with cesarean births. So I think part of it is different lived experiences that folks in different professions have. Folks who are obstetricians, we have all had some experience of a birth that, if we did a cesarean delivery later than we might have, we feel like, gosh, it was very challenging. It was hard to get the baby delivered. The mom had a bad infection. The mom had a lot of bleeding. Maybe people ended up in intensive care afterwards. And I think those really difficult experiences where your patient has a really negative outcome, for sure biases how you go into the next situation and want to make sure that you don't let something scary like that happen to a patient again in the future. Whereas if you're someone who most of the births that you care for are with folks who are generally healthy, who do well, your vaginal birth rate is quite high, you're going to be able to be and have a perspective that biases you more towards lack of intervention. So I think everyone in this profession, our midwives, our physician colleagues, everyone is, in general, obviously there's exceptions to every rule, but in general, we all go in trying to help birth be as positive and healthy of a process as possible. But we're all biased by what we've seen in the past and trying to avoid complications that we've seen or avoid adverse outcomes. And if the adverse outcome that you most hear about is an unnecessary cesarean delivery, you're going to advocate really hard to make sure this next patient doesn't have an unnecessary cesarean. And if the adverse outcome that you've seen is somebody getting really sick from a prolonged labor, you're going to want to make sure your next patient doesn't get really sick from a prolonged labor.
That makes a lot of sense. So then what do pregnant people do with these results? They hear them. How are they, of course, they're going to, talk to their care provider, but how are they making the best decisions for their birth based on all of this information?
Yeah. It is hard because, in this time of medicine, we're trying to both really individualize things and make sure everything's specific to the individual receiving care, as well as trying to help protocolize things so that our bias, be they, conscious or unconscious, aren't influencing how we're providing care. So it's this balance between not wanting to make your bias influence things, but also acknowledging each person as an individual, and you have to nuance the recommendations you give people. So I think for an individual person, it's helpful throughout their prenatal care to talk about kind of what's most important to them, what their values are, what their goals for their birth are, and to start those conversations early with their care team so that we can try to help you get as close as possible to the birth ideal that you want. Because there's trade-offs, whichever path you choose. So I think becoming clear on your own what your values are and then talking with your care team so you can help actualize those is super important. And I think just being open and asking questions. So if someone makes a recommendation, because maybe it's just the policy of that office that we deliver everybody at 39 weeks. But I think asking, gosh, tell me, for me as a person, why this might be advantageous. What risks does their provider see? And just making sure that the recommendation you're getting is unique to you and is consistent with your values.
Well, I want to go deeper to that because if they do hear, first of all, I love that you're really a proponent of not a one-size-fits-all policy. Just because they're 39 weeks, let's individualize it. But if they do feel like they're getting pressured, that office and practice does tend to have that. And I do hear a fair amount, this is just what my doctor does. And I'm always for talk to the doctor well before that 36 week. I'm actually talk to them before 23 weeks because it's harder to switch. But if they are feeling pressure, what are the questions that you would encourage them to ask their care providers so that they can be seen as an individual, not just a statistic?
Yeah. I think your point of asking early in prenatal care I just want to emphasize that because I think that's super important because there are different types of providers and we don't all click with everyone. And so you want to make sure that you're in a practice where what's important to you is important to them and you guys are on the same page with everything. So I just want to emphasize that that's really excellent advice. And so I think the important question is to really just ask for an explanation. And I think, depending on the practice where you're going, there are unfortunately sometimes pressures from insurance providers and things like that about how long a prenatal visit can be. And that is really unfortunate because I think it sometimes takes away the opportunity for more in-depth conversations. But I think, as early as possible, kind of talking about what does delivery timing look like? What might influence whether or not a doctor would recommend an induction of labor versus spontaneous labor to try to understand what their thinking is. And if you get an answer at 23 weeks that says we induce everyone at 39 weeks, then I think that gives you several appointments to say, gosh, I'm not sure I'm comfortable with that. Can we make a point to have a better conversation about that at our next visit so that the doctor and or midwife, whomever you're seeing, like really spend some time with you on that issue. Because you, I think, are owed an explanation, because an induction of labor is a medical intervention. And, if we were doing a surgery, I wouldn't just say, well, I just do this surgery. I would tell you why I'm doing the surgery, the risk and the benefits, and really give you an opportunity to consent and be sure that that's something that you want. So I think an induction of labor similarly is a medical procedure. And so your care provider who's recommending it has an obligation to tell you why they're recommending it, what the risk and the benefits are, and to really make sure you're a participant in that decision, just like you would any other medical intervention.
All right, I might be opening a very big can of worms. So I'm going to think of the demographic that I mainly work with, and I'm putting myself in this category. I was considered an older mom. I think it was called geriatric pregnancy, which is horrible. But I had my first at 37, my second at 40. And I would say in New York City, we tend to see people on that spectrum. And I know this wasn't specifically about maternal age, but that is something that I'm often heard. And not even like 40. I'm hearing like, I just turned 35. I'm 36. So kind of on the lower end of the beginning of the decline, I guess. What would you say? I actually had someone in my class this morning online, and she was 44, so she rocks. But what would you say if that was the only reason? If like I just turned 36, what are your thoughts on that?
Yeah. So I think it is a really reasonable question to ask. And of course, you need to look at the whole person. Is this someone who is 40 years old and very healthy, no medical problems, exercises, has the capacity to do that, all those things? Or is this someone who's 40 who has had a renal transplant and has high blood pressure? So there's different 40-year-olds, right? So I think if the only thing that is causing you to have a non-low risk pregnancy is that your age is over 35, I think it's important to like find out that that's the reason that someone's recommending a labor induction. Again, when we go back to the beginning of this, the reason folks thought of doing the ARRIVE trial was they were trying to prevent stillbirth. And stillbirth is one of the worst things we can think of. The only thing worse is, goodness forbid, if you lose a mom. But when we think about stillbirth, the risk of that does go up as moms get older. So it is not dramatically different for the mom who is 35 versus the mom who is 34 years and 6 months old. There's not a big difference in the stillbirth risk there. As we get later into our 40s, the risk of stillbirth at later gestational ages does start to get a little bit higher. So I think that if your midwife or physician says, I think we need to induce you because of your age, I would just ask them to quantify that a little bit more for you. Talk about what the actual risk is. Are there any risk mitigating strategies you could do if an induction of labor isn't part of your goals for your birth? And then, of course, to consider, are there other medical reasons that might be either placing you and or your baby at higher risk of continuing the pregnancy?
Thank you for answering that, because I was like, oh, am I going to jump into that topic? But I felt like we couldn't talk about induction without at least bringing the age situation up. Okay, We are going to take another break. And when we come back, what is one final tip or piece of advice you'd like to offer new and expectant parents? Okay, we'll be right back. Okay, we are back. So what is one final tip or piece of advice you'd like to offer new and expectant parents?
That is a big question.
It is.
I think I would say a couple things. One, I think finding a care team where you feel trust in that relationship, so that if there is a reason that labor induction or early delivery is recommended, you can have a open conversation and trust that they have your best interest at heart. I would say make sure you pack snacks in your hospital delivery bag, because the hospital food is often slow and hard to find. And I would say, there are a lot of different ways to kind of think through what your birth would look like. We created, inspired by one of the midwives who works in the state of Michigan, instead of a birth plan document, she made a document that she titled a birth partnership. And it was a tool, which you can find this online at the OBI website. If you Google it, you can find other examples of it. And the idea is that it is a partnership between you and your support team and your care team to make sure we're all on the same page and we're kind of partnering to make your birth as wonderful as it can be and make sure that you and your baby are as healthy as can be.
Oh, I love that. I actually you probably are in obstetrics. You've heard of Dr. Neil Shah, I'm guessing.
Yes, very much so.
He's done my podcast, I think 3 times. And one of the suggestions he had that he's put in a lot of his hospitals in Boston was to have a whiteboard and that everybody, like the parents' names are on there and the wishes, kind of the preferences are there. So when someone walks in, they see it right away. I thought that was brilliant. In fact, I always tell my students, I'm like, pack a whiteboard. So we're all on this. And then if things change, you can change it on the whiteboard.
Yes, absolutely. So I think starting that conversation prenatally with your care team to make sure the things that you're thinking are like everyone's on the same page about that. And then, the team birth is Neil's program, and it's lovely. It's something that we instituted at our institution and supported lots of hospitals around the state of Michigan to introduce because it's a great way to have a dynamic conversation that everybody can refer back to, make sure everyone knows each other's names. It's a great tool.
I love that because I think it is a team effort. And that way also the pregnant person is seen as a person, not just a vagina.
Yes, 100%.
So where can people find your work?
So I work for the University of Michigan. I'm the director of the Cardio-Obstetrics program there, so they can look me up via our website, and all my papers are available on PubMed, and I occasionally do speaking engagements or interviews. So, anywhere you Google, I'm happy to reach out to people. I'm also affiliated with the Preeclampsia Foundation if folks have questions about higher risk
maybe we'll do a
pregnancies.
podcast on preeclampsia. I think that's actually a fascinating topic.
Oh, yeah. Would be happy to anytime.
All right. We'll be in touch about that. Well, I want to say thank you. Thank you just for being so down to earth and explaining this trial that is confusing. So thank you for making it so understandable. And thank you for your time.
Oh, my pleasure. Thanks so much for having me.
This has been an episode of Yoga, Birth, Babies, produced by Prenatal Yoga Center. You can catch us on Facebook, Twitter, Instagram, and Periscope. I'm Deb Flaschenberg. Thanks for listening.